You've actually triggered some memories of what we did in South Africa. And I think I'm going to first put that forth as a case study, because I think there's some things, and I think it's going to segue into what Nasha actually wants to say. And then I'm going to, at the same time, maybe pose some propositions, having learned from our COVID-19 response in South Africa. So let me first put forward the case study. In South Africa, to respond to COVID-19, first thing that happened was that the president mobilized 500 billion rand of reserves into the active fiscus. And of course, a huge portion of that money was then going to go directly into the actual core COVID-19 response, including human resource, the growth of the human resources. So that was the first aspect. So I think the first thing to say about it is that that was state money, right? The second thing was that then we mobilized the private sector, and you will know very well that that mobilization resulted in the Solidarity Fund, which mobilized, I think it was about to the end, $3 billion as an addition as the private sector's contribution essentially to the fight against COVID-19. And most of that money went to the actual core COVID-19 response. So I'm talking about core COVID-19 response because I just want to focus on the health aspects and not the other socioeconomic, stimulus packages. Now, in terms of human resource development, we then, first of all, identified all the community health workers that we could. And then we also went to the external public works program, which falls under public works or not under health. And we recruited tens of thousands of external public health workers from that program and trained them to become community health workers. And in the end, we had 60,000 community health workers. We then deployed those community health workers in mobile vehicles to go into the communities. And this was particularly helpful because at the same time, that's when we had our hard lockdown. And then those community health workers were deployed across the country to all our 52 districts, and they did 20 million community screening and testings in all of the most vulnerable areas, which was excellent coverage. And in fact, I think this model was actually very commonly cited worldwide, as a good way of deploying primary health services, in response to a health emergency. And we did very, very well. And it allowed us to really pick up the first cases very early, and to survey very well. And we managed that first wave of the pandemic, I think, very, very, very well. What needed to happen for those community health workers to get out there? We needed to get vehicles, right? We needed to get them devices. So everybody talks about technology. What does it mean? It means that we need either a pad, a tablet, or a phone. We needed to develop very quickly an application that was going to interoperate with our labs and other existing digital systems, so that you will know all about that, so that there was good central reporting and we were able to actually survey in real time. We needed petrol to get them there. So how did that all happen? We had Highway and Mara phones, which unfortunately collapsed. They donated, I think altogether, they ended up donating about 30,000 devices. And these devices were given to the community health workers and off they went. Engine came on board with the petrol. And then, of course, part of that 500 billion, we bought a whole lot of PPEs, right? Then next, we needed more nurses, right? So the first thing we did was we looked at the nurses that were still training or that were close to kind of qualifying, and we got them across the line as quickly as possible. We employed every single nurse that we could find. And I think eventually in the end, we ended up adding 16,000 nurses to the workforce that was going to respond to COVID. How did that happen? We had to go to the Minister of Labor and the Minister of Finance, get the money from the Minister of Finance and Minister of Labor to expedite the employments and give everybody 6-month contracts. And this also had to happen with the 60,000 community healthcare workers that were recruited. Now, what is there to be learned about all of this? First of all, we all know that as we talk about universal health coverage, it cannot happen without the state, right? But in Africa, we tend to deploy these wonderful catalytic programs. And then when the catalytic programs come to an end, then the states must pick up, you know, and they can't. And hence the programs come to an end, and then we find that we're going 10 steps backwards again. So ultimately, one always, when supporting states with health workforce development, we must also support the states to be able to sustain this health workforce over the long term. So that's the first aspect. The second aspect is that after 6 months of us employing and paying these health workers who are obviously, I would say they were 90% women, you know, that were recruited into the response, to the COVID-19 response. The next thing we found ourselves having protests. I remember this very well. Everywhere we went with the Minister of Health, there was a protest. What were they protesting about? A couple of things. Firstly, they wanted to carry on working. You know, they were having a fantastic, a wonderful time with the communities. The communities were appreciating them. You know, the facilities were appreciating them, and they wanted to carry on working and they wanted to be employed. But they didn't just want to get a stipend now. They wanted to be employed with full employment benefits, number one. Number two, they wanted to be properly dressed and they wanted to look professional, you know? They were saying that we don't want to wear our little tracksuits and all that. We want proper uniforms, want to be recognized in the community, because first we want to be protected. If you're recognized as a community health worker, you're protected, you know, by the community. Secondly, people then know who you are and they know where to find you and they know how to seek, etc., you know. So they just needed clothes, you know, proper clothes to make them look professional, you know. Thirdly, they wanted to keep these devices and they wanted to keep these apps, and they wanted to be able to actually use these devices and this technology to carry on with the work that they were doing. They didn't want them to be taken away because it was so helpful to them, you know. And then fourth, which it came as a surprise and shouldn't have come as a surprise to me, they also wanted good health care themselves. They didn't have good health care for themselves, you know. So when they got sick, you know, they found that they didn't actually have the health care that they needed to, you know, to stay healthy and to carry on doing their work. So all of that needed to be financed. And then that's when we got stuck. We only had a stimulus package which drained our reserves. Now we are stuck. The Minister of Labour is saying that it's going to be difficult to actually properly employ them with full benefits and all of that. The Minister of Finance is saying we don't have money, you know. And what happened next? They went to the unions, and now we're still busy dealing with the unions, and the unions are fighting on their behalf. So all of these things I'm pointing out, you know, as we're thinking about deploying female health workers into primary health care, that they have got, we have to have the foresight to consider all of these aspects down the line and understand that our partnerships must ultimately pursue the kind of financing models that we know work for universal health coverage. And it cannot be, we can no longer afford to only think about short-term catalytic programs. There was one other aspect that I wanted to point out. Oh, yes. One other aspect is insurance for female health workers, right? Not just health insurance, but just life insurance, you know. I remember when I was pregnant with my first child, I didn't want to work. I wanted to spend 6 months with him, you know. So I saved up and all of that, but it wasn't enough. And I forgot that we have UIF, but even if I remembered, it's only a tiny little bit of money. And it occurred to me that why can't I have insurance for, you know, life things, you know, as a woman health worker? Why can't I have insurance for maternity leave, you know, to ensure that I actually have enough money to be able to not work, but then, return to work, having raised my children, having taken care of myself, having my well-being, comprehensively taken care of. Why can't I have insurance for, as a woman? We all know that women are the caretakers. If my mother gets sick and I need to, take off, why can't I have that insurance that, if I need to take off a couple of months to look after my dying mother, et cetera, et cetera. So that was another thing that came out from the workforce, is that we need protections, we need protections and reassurances that if we have to pull ourselves out to take care of community members outside of health service, we will be welcomed back again.